Great. Thank you so much for having us. Melissa, would you like to do the introductions of our panelists?
I would love to. And I just, first, we should probably introduce you, Helen, although you were just introduced. Thank you so much. Helen's the Associate Professor, Department of Ophthalmology um, at the University of Toronto and the Department of Ophthalmology at the Children's Health Evaluative Sciences and Center for Global Children's Health at the Hospital for Sick Children. And then we also have Lucy Jambi, who's a pediatric ophthalmologist and lecturer at Kenyatta National Hospital and University of Nairobi in Nairobi, Kenya. We have Jessie Berry, who is Associate Director of Ocular Oncology and Associate Professor of Ophthalmology at Children's Hospital Los Angeles and USC Roski Eye Institute in Los Angeles, USA. And Laura Kelly, a retinoblastoma survivor from Halifax, Canada, and she serves as a retinoblastoma champion within the Canadian Retinoblastoma Research Advisory Board. Thanks so much, everyone, and Helen will get us started.
Great. Thanks very much, Melissa. I'm going to kick off our panel with a short introduction to retinoblastoma genetics, which is really just to answer a few of the high-level questions we received from the audience members before today. And so essentially we'll cover what causes retinoblastoma, the genetic development of retinoblastoma, how it progresses, and hopefully this will be a nice little primer to get you following the talks from the rest of the panelists, which will follow this one. So in order to really think about what causes retinoblastoma, we have to go back a little bit to our science lessons from school and remember that genes make up the recipe of life or the instructions of how our body grows. And our body is, of course, made up of a number of cells, and inside these cells are DNA, which encode our genes, and they're packaged up into these chromosomes. And we have 2 copies of every chromosome. And cancer is essentially a disease of the genome, which means that there's something wrong in the instructions in the genes that tell our body how to grow or replicate cells in an erroneous fashion. And so for retinoblastoma, we know that most often this instruction that goes wrong is in the RB1 gene. And so that's shown here. It's a gene that's on chromosome 13. It's important for cell growth. It's important for keeping DNA healthy. So you can see that when this doesn't work, it doesn't operate optimally, it can give the wrong instructions to cells about growing and protecting DNA. There's also a rare form of retinoblastoma, and that's caused by amplification or too many copies of a gene called MYC-N. And too many copies of this gene also tells the cells to keep growing. So we'll go through each of these one by one. For the most common type of retinoblastoma, they're initiated when both copies of the RB1 gene are inactivated. And so these are termed M1 and M2 events. And the timing of M1 really tells us if retinoblastoma will be heritable or non-heritable. So if that first copy of RB1 is inactivated early on in development to affect all the cells of the body, or it's inherited, that's heritable. If M1 occurs later in development, only in that cell in the eye that will become the tumor, it's non-heritable. And the second event is always at the level of the tumor. And yet loss of RB1 is really only enough to get the tumor started. It'll become a benign form of retinoblastoma called retinoma, shown in this picture of what tumor looks like under the microscope. And we know that in order to progress to retinoblastoma, we need other mistakes or issues in the cell's instructions in DNA. And these are called M3 to MN events. And we know there's a number of them. We're not quite sure the exact order or if they're always in every cell. We're still doing a lot of research on this, but essentially we know that sometimes there's too much of certain chromosomes and specific genes. Sometimes there's too little. Sometimes there are specific errors or mutations in given genes. And sometimes they're what are known as epigenetic problems. So that's how the DNA is packaged, which turns some genes on or off when they shouldn't be working that way. And in the final photo here, you see what retinoblastoma looks like under the microscope. And it has very distinct features from retinoma. It has many more cells, they're packed together because of course they've been growing, and they form these little clusters called rosettes. And whereas in retinoma, you'd see a different type of structure called a floret. The second pathway to retinoblastoma tumor development is because of too much of that gene called MYC-N. And so essentially that gene is on chromosome 2. Shown in the photo, you can see how this one chromosome is extended a bit because of the many more copies of MYC-N. We know that this only happens at the level of the tumor, so it's never in all the cells of your body, never something that's heritable. We don't know if additional genes are changed in its development, but what we can see of that tumor under the microscope is it looks very different than the tumor caused by RB1 mutation. It has these round cells, very prominent nucleoli, and it looks a lot like another kind of cancer called neuroblastoma. And so these are the two main forms of retinoblastoma that we know of. Of course, we're still learning more the more we get to study tumors. So we had another audience question, and that asked if the RB1 gene is expressed in many types of cells. As we said, RB1 is important for cell growth. It's important for keeping DNA healthy. So why is it that people with heritable RB1 mutation usually present with retinoblastoma first? And so that's a very good question that we don't quite know the exact answer to. We know that there's something about the way that the infant retina develops that makes it uniquely susceptible to loss of RB1 as an initiating factor. So something about the instructions for that particular cell, it needs RB1 early on in its recipe. And when it's gone, it's enough to initiate retinoblastoma. We know that RB1 is important for the development of other cancers. It's why individuals with heritable retinoblastoma are at higher risk of developing cancers later in life. But for those cancers, the role of RB1 is not an initiating role. It actually aids in the development of cancer if it's not there, but other factors are what initiate those other kinds of tumors. And so that's a very brief primer so that you can now think about how what we know about retinoblastoma genetics can be used in genetic testing and counseling and consequences for families. So Melissa Mills will start that discussion off as a genetic counselor herself and as a survivor of retinoblastoma. And then you'll hear from the rest of our panel about more on genetic testing, new research, and how genetics has impacted the survivor experience. So I'll pass it over to Melissa now.
All right, thank you so much, Helen, for that introduction. So like she said, I am Melissa Mills, a genetic counselor and a bilateral retinoblastoma survivor. And we thought I might be a good person. We have a lot of questions that came to our panel ahead of time that folks were interested in getting answered. So hopefully I am the right person to help answer those. So a little bit about my background. I was diagnosed in 1976 at 11 months old in Boston, Massachusetts. My left eye was enucleated almost immediately at Mass Eye and Ear in Boston. And then my right eye was successfully treated with cryotherapy only. And I do have vision right eye. So fast forward many years, and I actually went to a genetic counselor, found my RB1 mutation. And after that experience, I said, wow, I really want to help folks with genetic conditions learn about their genetic information and be empowered by that information. So I went back to school and became a genetic counselor. And I'm currently working very part-time as a prenatal genetic counselor. I'm not here representing my institution, just myself. And I am raising identical twins during a pandemic. That's a lot of my time. So Helen did a great job already bringing this in, but I feel like it can't hurt to reinforce a little bit. And as a genetic counselor, this is kind of where you start, the importance of understanding some of the basics of genetics. And so, basically, we've got, I'm trying to go back to the cell, as Helen said, in every cell in our body, in the nucleus or the center of that cell, that's where our chromosomes are. Those are the packages that tell us how to grow and develop and what we look like. And if we unravel those packages, that's what this picture here is showing. If we unravel that DNA, there's a code, and you read the code, and that's the gene. And the problem with the RB1 gene for retinoblastoma is there is a change in that code that causes that gene not to work. And that's really problematic because that protects us. It's a tumor suppressor gene that protects us from cancer. So we're missing a protection from cancer. This next slide shows chromosomes in one cell under the microscope. As Helen said, there are 2 copies. We get one from our mom and one from our dad. So folks like myself who have an RB1 mutation, we have one working copy on one chromosome and one non-working copy on on the other chromosome. And super briefly, because she went through this, the point of this slide that it just shows here that when you're someone with an RB1 mutation, you're starting with that mutation in every cell. And so that protection from cancer is missing. Whereas folks with unilateral, sporadic, they don't start with that missing protection. Now, how does somebody know if they have an RB1 mutation? And I've got a little schematic here, but I'm going to talk it through. So basically, if you have a family history, we're 100% sure that there is an RB1 mutation, so a change in the gene is the mutation that caused that retinoblastoma. Whether or not we can find it, that's another question with testing and things like that. But we are 100% sure that folks with a family history, whether you have cancer in one eye or both eyes, that we actually know that that there's an RB1 mutation there. So then we get over into the no family history. Okay, so you've got no family history and you're bilateral like me. It's close to 100% there that there's an RB1 mutation. And then unilateral, one eye. So with that one eye, did you have multiple tumors in that eye? Well, then it's 14 to 95%. That's a big range. Genetic testing can be really important to help pin down what's going on for those folks. And then if you're unilateral and then just one tumor, one spot, unifocal, approximately 14%. That's not zero. So again, genetic testing is important to kind of help us know what's going on for those cases. Now, one of the biggest questions that we get is, how did my child get hereditary retinoblastoma when no one else in the family has had this? That's actually the case for me. I am the only one in my family to have retinoblastoma. And basically, I have a de novo hereditary retinoblastoma. So I have a new mutation. So in genetics, we say that's a new mutation that occurs for the first time in a family member. So this can happen when it's never been in the family before, and then I can pass it on to my children. So and when I speak to my prenatal patients, I actually explain to them, like, how does that happen? Well, in any pregnancy, there's a chance of something. We have 25,000 approximately genes in the human genome, and at a minimum, 1 in 40 people is likely to have received a newly mutated gene somewhere. Now, it turns out that retinoblastoma, although it's rare, we do find that if you look into the literature, that it is something that does get these mutations. And that actually leads me to my next slide, which folks have asked, are there medical or nutritional correctional measures to be adopted by parents to prevent gene mutations that lead to retinoblastoma? And the answer is no. This is just something that happens. It's by chance, and there's nothing anyone did or didn't do to cause these new retinoblastoma mutations. So I think it's really important. I think there's a lot of angst when this happens because you want to know why. And sometimes there is not a good answer to why, but it's really important for folks to grieve that loss of the expectation of how things were going to go, because it is a hard road. And it's okay to process that and grieve that, but it wasn't something that someone did or didn't do. It's really important for folks to know that. Now, another question we get, and this is a little bit tricky. I wasn't able to do a description. For most of my images, I've tried to do a description actually written on the slides, and trying to describe it for you folks as well. So this is a question we get. What is the chance for my children to have this if I have hereditary, I have an RB1 mutation that can be passed on to my children? So the first, this is called Punnett squares. This is how we figure out the chances in genetics. So we've got these squares here, and basically all this image is telling us is, okay, So if you're a carrier of retinoblastoma, there's a 50-50 chance of your children to have that RB1 mutation. So whenever you go to make egg and sperm, either there's the mutation is in there or the working gene is in there. So it's 50-50. It's like flipping a coin, statistics of small numbers too. And then on the other side of the slide here, it shows we have 2 retinoblastoma mutation carriers having children. We are meeting each other through survivors and wonderful meetings like this. And so that is actually a different case. There's 4 options, but one of the options is both retinoblastoma mutations are inherited. And that actually is not compatible with life. That would be a miscarriage. So we don't include that in our calculations for what are the chances for a child to inherit retinoblastoma. So in this case, it's a 2/3 chance that a child will have retinoblastoma and a 1/3 to have no mutation, no retinoblastoma. Now, why is it important to know about an RB1 mutation? Well, that can help inform patient care. And it can also help you find out about if you are one of those folks that's going to have a 50-50 chance of passing on mutation, so that we can make sure to test children early and things like that if we know that risk is there. It allows for testing for siblings so they can receive or not receive screening as indicated. I have a younger brother who had lots of screening in the 80s. If we had had genetic testing, he wouldn't have had to have any of those. And that's a huge savings for folks in time, money, and stress on families that are already having a really hard road to travel. Also allows for survivors to advocate for themselves and get correct screening throughout their lifetime. Another question we always get is implications of a genetic diagnosis on family planning. Now, I could do a whole talk on this. So I encourage folks to go to the We See Hope website and look at a blog post that I wrote. It goes really into great depth into details about each of the options that you have. It has personal stories about how people made decisions about family planning. And I think it's really important for folks that if you're struggling with that, to go there and do some deep searching about what would be the right decision. But really briefly, I'm going to talk about IVF with PGD that can be done before someone's actually pregnant, if your RB1 mutation is known, prenatal diagnosis during pregnancy, and then ultrasound and MRI later in pregnancy. That can be done either way, either if you know your RB1 mutation or if you don't. So very briefly, IVF with PGTM or PGD. So that's basically in vitro fertilization. So you're creating embryos outside of the body in a petri dish, and then you're testing those embryos to see if those embryos have retinoblastoma. This image here shows a blastocyst having cells taken out so they can be tested for retinoblastoma, and then ideally you can transfer unaffected embryos. So then the other prenatal diagnosis, you have CVS, which is a placenta test done earlier in pregnancy, and then amniocentesis showed here on this slide, which is done around 16 weeks of pregnancy. In both those cases, you need either a piece of the placenta or fluid with cells from the pregnancy to test for retinoblastoma. That can be really important to know if a pregnancy is affected, because sometimes they may want to deliver early for a pregnancy at around 36 weeks, because we now know that 30% of babies with an RB1 mutation, they can have tiny vision-threatening tumors at that gestational age. So it's very important, can be very important to know if a pregnancy has an RB1 mutation. So another question we got was, what chances do kids have to develop another cancer if it was random? And this was actually a little bit of a tricky question for me, because what exactly do you mean by random? Because I feel like it was random that I was the first person in my family and the only person to have retinoblastoma, but I have some lifetime risks of additional cancers for sure. I think the question is asking, what about those unilateral, sporadic, no family history, no RB1 mutation? Well, then no, those kids do not have the same risk for additional cancers, whereas survivors like myself do have additional risks. And that's different than recurrences of cancer or things like that. I wanted to spend time on survivor issues because that's near and dear to my heart as a survivor, but that was covered wonderfully yesterday in the survivor panel. So I'm just going to add one little additional nugget of information. On the We See Hope website, there is actually a form that you can print out to write down what your child's treatments were and diagnosis and things like that. You can also request copies of records from the institutions where your children were treated. It's really good to do that sooner rather than later, just to get that in the file for your child to really empower them later in life. We have to be our own advocates. We have to know about our genetics, and we have to go and tell our providers about this a lot. And so that's a really important piece that you can do to help your children later in life. Now, this has been a really fast talk. And so I've put together a list of resources. If you would like more clarity, there's resources here for you. If you'd like to go deeper, there's resources here. And then I put my email at the bottom. I'm so sorry it wasn't on the ones I submitted for the conference. I forgot, but it's there now. And I'm happy to help answer questions. It's also on that We See Hope blog post. You can find me there as well. And now, thank you so much. It's such a privilege to speak to everyone and to be back at this wonderful conference. And now I'm going to pass over the baton over to Lucy Jambi, who's going to talk about her experiences in Kenya and lower income countries. Thank you so much, everyone.
Hello, everyone. It's a pleasure to present to you about retinoblastoma genetics in low and middle income countries, the Kenyan perspective. The objectives of this presentation is to highlight retinoblastoma genetics work in Kenya and to outline our next steps. As part of background information, in 2008, the Kenya National Retinoblastoma Strategy, KNRBS, was formed with the aim to improve survival and outcome of children with retinoblastoma in Kenya. It had 4 pillars. The first one was medical care. The second one was raising awareness. Third is collaboration and networking. And the fourth one is family support. Under medical care, we had 2 objectives: treatment guidelines and development of genetic services, which is the interest of our talk today. For us to be able to develop targeted genetic services, we identified 3 main areas to focus on, and this included genetic counseling, molecular genetic testing, and surveillance for other cancers. To start us off, in 2013, we set off to do a situation analysis research, and this involved interviewing the medical workers and clinicians and patients and survivors and parents of retinoblastoma to find out the background information or about the genetic services in the country. From the study, we were able to identify challenges related to genetic services. We grouped them mainly into 2 categories: the doctor's perspective and the patient's or survivor's perspective. From the doctor's perspective, the key points identified as challenges, the first one was there was no genetic counseling unit, neither training nor counselor related to retinoblastoma. There was also lack of genetic testing services in the country. The clinicians have also limited knowledge and skills, knowledge related to genetics of retinoblastoma and skills related to genetic counseling. They are also overworked and overwhelmed with very limited time to do anything else except the clinical work. And this leads to frequent examinations and anesthesia for patients who are at risk or who are suspected to have retinoblastoma, and leading to overload and overworking of the clinicians. From the patient's perspective, this included the parents and the survivors. The main points identified as challenges included: 1, self-blame and denial about the diagnosis. There was also the issue of late presentation and poor follow-up and financial constraints, which when patients present late, the clinicians tend to concentrate more on containing the disease rather than offering genetic services. The educational, religious, or cultural diversity of the patients and the parents and the community, they strongly influence the understanding and the decisions that are made about retinoblastoma diagnosis and treatment acceptance. This was highlighted very well by Michelle's testimony about the religious and the cultural impact about the diagnosis and the stigma surrounding retinoblastoma. There's also the issue of translation of complex genetic information into local dialects. There is no direct word for gene into the local dialect, and many times the clinicians use alternative words which don't necessarily give the same meaning. Another important role is the mother's role in the African community, that mothers are not able to make independent decisions regarding accepting treatment of the children needing any form of treatment without involving the father, the clan, and sometimes the community for consent. And sometimes you have the conflicting ideas, and therefore you may find that the treatment is delayed or even denied. We went further to find out about experiences of survivors of retinoblastoma patients and their parents regarding the genetics of retinoblastoma. And we carried out another study in 2017 to find out the understanding about the genetics of retinoblastoma. And in summary, the findings of this study shows that the origins of retinoblastoma are unclear. And there was also a challenge in understanding the genetic origin of retinoblastoma. And many times the parents would ask, how would you say this child has a genetic disease, yet neither of the parents nor the grandparents have the disease? So you find that there was a confusion about the word gene and the word heritable. When you mention the word is genetic, the parents would understand that this is a heritable disease. And this is a similar question that Melissa has just highlighted in her presentation, where patients and parents seem to find that the word genetic means heritable. We have established the benefits of genetic services in Kenya through this study that we carried out between familial retinoblastoma patients at SickKids Hospital and those at Kenyatta National Hospital. And what we found out was early diagnosis and better outcome were consistent with genetic counseling and testing. Of note is that all the familial retinoblastoma patients at SickKids Hospital undergo genetic testing and counseling, while in Kenya, the children with familial retinoblastoma, the genetic counseling is not consistent and it is not carried out by professional counselors, and as yet there is no testing in the country. So to be able to scale up retinoblastoma genetic services in Kenya, we have identified a three-pronged approach where we'll look at medical education and molecular testing. Our next point will be to look at patient and family counseling. And the other component is to involve the community, because we may not be successful if we leave the community behind. And this way we'll be able to break this cycle where we have survivors of retinoblastoma presenting with children who have advanced disease that may need aggressive treatment and invasive treatment, such as enucleation, or sometimes lead to death, as unfortunately has also been shown by Michelle in his testimony. Thank you very much for your attention. This work has been made possible through the collaboration of SickKids Foundation and the University of Nairobi in Kenya and Kenyatta National Hospital.
Hi everyone, as Helen said, my name is Laura Kelly and I am an RB survivor. I was born into a family with a history of heritable retinoblastoma. And today I'm going to be sharing my family's retinoblastoma journey. So this all began long before I was born. Highlighted in this pedigree, my grandfather up here, number 2, and 3 of his siblings were identified as ineffective carriers of the RB1 gene mutation. One of his siblings was a carrier and also ended up developing retinoblastoma, which would be over here, number 8. So he ended up passing this down to 4 of my dad's three of my dad's siblings, sorry, including my dad as well. And they all developed retinoblastoma, and in result of that ended up with all of their, at least one eye enucleated, one had two, which would be here on number 7. So some of my dad's cousins that were older than him actually had retinoblastoma, which kind of prompted frequent eye tests, which is how they came to discover the retinoblastoma. My uncle Terry, who would be number 7 here, he has a son, Jeff, who also developed retinoblastoma. And at the time in 1976, when Jeff was born, there was no genetic testing to identify that he had carried the mutation. So on December 16th, when I was born, genetic testing had been established. And because this mutation was presented, retinoblastoma, and many of my family members before me, I was genetically tested to determine if I was a carrier. So I was in fact a carrier, and my eyes were monitored every few weeks until May of 1994, when 2 tumors were detected in my right eye at 5 months of age. I began treatment at Toronto's SickKids Hospital the following week, and after 9 treatments of laser, I was cancer-free in April 1996. I had many eye exams under an anesthetic in Halifax following those treatments. And at 20 years old, I went to genetic counseling, which allowed me to better understand my risks of secondary cancers and how this genetic mutation would be carried on to children if I decided to have children in the future. Genetic testing has really impacted my life and in fact saved my eyesight. Unlike many other retinoblastoma survivors that I know, I was not a de novo case, as Melissa had mentioned previously. I really benefited from genetic testing because once they were aware that I was a carrier, of course, I was monitored on a regular basis, and this allowed for early diagnosis and treatment. And I know that was really short and sweet, but that's pretty much my family history and how genetics has really come a long way. And I'll try and hand it back to Jessie.
The goal of my talk is to bring some awareness to a problem that we face as clinicians who take care of retinoblastoma, in a way in which I hope that in the future this will change, using the aqueous humor as a liquid biopsy for this disease. And I'll explain what that means. What is listed here are my grant funding, which does support the research that I'll be speaking about today. So this is the dilemma that many of us who treat the patients who are here as survivors and the parents know. We will take 2 children into the operating room that look exactly the same. The volume and amount of tumor and seeding and subretinal fluid in their eye looks very similar. We will give them the exact same treatment, and we have very, very different outcomes. One patient will look like this. This is a cured eye, an eye that has been cured of retinoblastoma. You can see a normal calcified tumor, and there's the optic nerve, no evidence of disease. That's the outcome we're aiming for. However, about 50% of our advanced Group D and Group E eyes will continue to have persistent or recurrent disease activity until we say we can no longer safely treat the child and have to enucleate or remove the eye. And as clinicians, we'd like to be able to predict which eyes are going to do well and which eyes are going to do poorly. But we are limited in our ability to do that because, unlike other cancers, retinoblastoma cannot be directly biopsied. And this is due to concern for bringing that tumor outside of the ocular space. And when you do that, or if you were to do that, you actually put the child's life at risk. So it's something that no clinician ever wants to do, and it is not done in clinical practice for this cancer. However, in 2012, an ocular oncologist in Switzerland, Dr. Munier, redesigned a technique for injecting chemotherapy directly into the eye itself. And in order to make that technique safe And to keep the overall volume in the eye the same, initially a small amount of the clear fluid in the front of the eye, which is called aqueous humor, was removed. This has now been shown to be safe over multiple years of follow-up and multiple injections. And because for the first time we had access to something from inside the eye in eyes that were undergoing treatment, it allowed us to ask a really critical question, which was, with safe access to this fluid, can we use this as a surrogate to tumor biopsy or as a liquid biopsy for retinoblastoma? You might have heard the term liquid biopsy thrown around in the popular press, but what it means is a non or minimally invasive test of a fluid. In our case, we're talking about aqueous humor, but the most common is blood. It can also be urine, CSF, which is the fluid that bathes the brain, or even saliva. And it's meant to detect either cells from the tumor that have broken off, or more frequently, the cells have broken open and the contents of the cell, like DNA, which we've learned about, are in the fluid. And so this is a complicated slide with our workflow, but what I mean to show you is that we take a very small amount of fluid from the eye and we extract the DNA, which again is the code for how the cells to work from that. On the bottom of the slide, you can see that a flat line means that all of the chromosomes in the cell are normal. It means there's a normal count and there's 2 of each chromosome. But retinoblastoma, like other cancers, have too many or too few parts of those chromosomes. And so when you evaluate that, instead of getting a nice straight line, what you actually have are areas where there's a spike above the line, that's too many copies, or a dip below the line, that's too few copies of what we would consider normal for our chromosomes. And so in our initial evaluation of whether or not we could use the aqueous humor, we looked at eyes that were enucleated so that we could evaluate the aqueous humor against the tumor. And what you're seeing here are a bunch of complicated shapes. I don't want you to focus on what each shape means, but rather look at the similarity between them. Case 1, again, is a primary enucleated patient. We evaluated the DNA that was found in the aqueous as well as the DNA that was found in the tumor. And you can see here in the overlap, it overlaps so beautifully, you almost can't tell that there are 2 lines. But what this shows is that what we found in the aqueous, the areas that were too many chromosomes and the areas that there were too few chromosomes, was exactly the same as what was found in the tumor. Case 2 here is a patient that's predisposed to developing retinoblastoma due to a loss of the retinoblastoma gene throughout their body. And this patient had multiple different tumors in the eye, all of which contributed to the aqueous. So you can see here the overlap here is quite good, but not perfect. And that's what we would expect when there are multiple tumors with different changes in the eye. Case 3 here was our cincher. This was a patient that was undergoing treatment to try to save the eye. And with every injection of chemotherapy, we took the aqueous. This line is very complicated. There's lots of areas where there's too many and lots of areas where there's too few components of those chromosomes. But I hope you can appreciate that over time with every injection, the line looks the same. So we were getting the same information. Unfortunately, there was a tumor recurrence in this eye, so it had to be removed. But what it allowed us to do was look at the tumor and prove with great confidence that what we had been seeing all along in the aqueous was in fact DNA that was coming from the tumor. And this bottom slide here shows the overlap. And again, it's so good, you almost can't tell that there are multiple lines here on top of one another. So once we had proven that you could find DNA in this fluid, we then went on to study more patients and more eyes. We found, again, these are the overlapping profiles, that the aqueous continue to be very concordant, which means similar to what you find at the tumor. That's what you want in a liquid biopsy. You want to know that it is being a surrogate of a tumor biopsy on its own. And for the first time ever using this technique, we were finally able to compare tumor DNA from eyes that were removed and from eyes that were saved, because in the eyes that were saved, we were getting the tumor DNA from the aqueous. The red line and the blue line here are from those two groups. The blue line is from the eyes that were saved, and the red line is from the eyes that had to be removed due to aggressive tumor activity. And what you'll see here is there's a very large difference right here. This is chromosome 6p, and there's a much higher complement of there being too many copies of that 6p in the eyes that had to be removed. And when you look at whether that matters based on grouping, of course, everyone here knows that grouping is the characterization or the categorization of these eyes from A to E, where A eyes do better than B eyes, all the way down to groups D and E, which are more advanced eyes. This line tells us how those eyes survive. And of course, the group D and the group E eyes are more aggressive and have to be removed more frequently. But when you look at whether or not there was 6p in the aqueous humor, this division is really dramatic. These eyes at the top did not have that increase in the number of copies of 6p, and they survived. That's why the line stays high. Where these eyes, unfortunately, did have aggressive tumor behavior and had to be removed, and these are the eyes that had that 6p gain present. This is here showing that the same thing persists with group D eyes and group E eyes. Here in our group E cohort, the only eyes that we were able to save were those that did not have too many copies of this chromosome. And in fact, there was a 10 times increased risk that an eye would have to be removed if 6p gain was present. We've now doubled the number of eyes that we've looked at and doubled our follow-up, and this line is remarkably similar. Eyes that have lack of 6p gain or have a normal copy number of that area of the chromosome do quite well, where those that have too many copies often show aggressive tumor behavior and require removal to save the child's life. That's when you look at a single sample, but many of the parents who allow their children to be part of this wonderful research actually ask, well, does it matter if you take the fluid just once, or should you evaluate that fluid over time? And this is a wonderful case that demonstrates that evaluating the fluid over time can help you predict if an eye is going to recur. So this is a patient that had active tumor in the eye, was being treated. And you can see here again, a very complicated line with many areas of too many parts and many areas of too few parts of those chromosomes. However, with injections, the lines normalize. That means that the tumor DNA was going down and we were not seeing a high enough fraction of DNA in the aqueous. That's what you want with treatment. However, this line here shows an uptick. That uptick suggests that the amount of DNA is rising again in this fluid. And here with sample 6, there was a clear recurrence in the eye and all of those alterations were back. So what we hope to do in the future by monitoring these samples through time is actually pick this up at sample 5, where there's that little tiny uptick. And then you know that an eye is recurring before you can even see it as the physician taking care of these children. That has the potential to be very impactful. We've talked about RB1 mutations today, and yes, you can find both of the RB1 mutations in the aqueous humor, and this also helps us test the blood better so that we can make sure that the blood test is even more specific for determining whether that mutation is just in the tumor or in all cells of the body. And here again is our workflow for that, which is very complicated, but just to show you that with a very small amount of tumor DNA in the aqueous humor, we can still find these mutations with very high frequency. Now, everyone wants to know, can't you just use the blood? Because of course it's easier to take blood than it is to take this fluid from the eye. And the answer in our hands so far has been no. The amount of DNA that's in the aqueous, because that fluid is separate but still very close to the tumor and it is from inside the eye, is much, much, much higher than anything you would find in the blood. So to date, we have not found DNA at a measurable level that is clinically impactful in the blood of retinoblastoma patients. So in conclusion, this is a work in progress led by CHLA, but I'm really grateful that centers across the country and expanding to other countries have joined us in sending us their samples and having their patients participate in this research. Evaluation of the aqueous as a liquid biopsy has diagnostic implications in terms of being able to identify the RB1 mutation, but I'm really excited about the prognostic implications, not only identifying recurrences, but helping us understand which eyes are likely to have more aggressive tumor behavior. We expect that as this research continues, there will be more novel insights into how these tumors form, and maybe one day we'll even be able to dictate our treatment paradigms based on what we're finding in the aqueous. We've published multiple times on this. You can Google this and find this information, or reach out to me if you're interested in some scientific reading on a Sunday. I'd like to thank my laboratory team. It is a group effort to take care of this research, and also to all of the parents and the patients who have been brave and participated in this new research program out of Children's Hospital Los Angeles. Thank you so much. So I think now it's time for our panel, although I don't know how much time we actually have. Helen, do we have time to take some questions?
I think that's up to Caitlin and team.
Yes, we're going to get to a few questions before we wrap up for our break. We do have a question from an audience member who would like to verbally share their questions, so they'll be invited to speak now.
Oh, thank you so much for this lovely presentation on genetics. I am Dupe, speaking from Nigeria, and I really appreciate the opportunity to attend this and the new perspective you are giving us on this. Now, the 6P, I'm just more interested in the genetics. The 6P, okay, you just presented about the increase in the 6P in those patients that did not respond well to treatments compared to those that were easier to treat. I'm asking at the moment that are there specific drugs that are now being used or in trial that can help to control for this in the patients so as to improve the outcome?
That's a great question, and that's a priority for our lab to better understand. So not to get into too many details, but the 6P is often gained as a whole arm. So when Helen and Melissa showed you the pieces of the chromosome and pointed to specific genes, we're not seeing a single gene amplified, and usually drug targets would be against a single gene. We're actually seeing an entire segment of the chromosome with multiple genes amplified. So many people have done a lot of great research on this, and still, whether or not there is one or multiple genes that are active on 6P is unclear. I hope that by finally being able to compare eyes that do well with eyes that are enucleated, and of course those are the only ones historically that have had tumor involved, we'll start to understand if there are differences. And with more samples, maybe we will get down to a smaller region of amplification so that we can narrow our gene targets. So that's the long answer, but the short answer is no, there is no targetable drug right now.
Thank you so much.
If I could add to that, Jessie, isochromosome 6P was looked at for the, as you said, there's not a single gene, but there is a body of evidence pointing to DEC and E2F3 as potential genes that contribute to retinoblastoma development. So maybe that's some area for future work.
Another question from the audience was, how do you manage multifocal and unilateral retinoblastoma or bilateral retinoblastoma children with no RB1 mutation detected? I'll say that again because I was a bit clumsy there. So how to manage multifocal and unilateral RB or bilateral RB child with no RB1 mutation detected?
So depends on how the person asking the question intended to ask it. No RB1 mutation detected, do they mean no test was done? Or do they mean a test was done and didn't detect an RB1 mutation? The two are slightly different. So if you're in a setting where there's no genetic testing, but you can phenotypically see that there are multiple tumors in the eye, that's a hint that this is heritable retinoblastoma and should be managed as such. In fact, if you did do a test there as well and didn't find an RB1 mutation in the blood, I would say perhaps the sensitivity of your test is not good. Hope that answers. Does anybody have anything else to add?
Okay,
That's a perfect answer.
we have another audience member that would like to talk. Please go ahead. Oh, please go ahead now.
Hi, Tracy. Bhavna here. Excellent presentation from all of you. So I just had one question from Jessie. So great talk. I wanted to know is that do you advise some special precautions while drawing aqueous from retinoblastoma eyes?
That's a great question. And we're actually putting a methods together, collection together to actually show that in video for people who are interested. The majority of the aqueous that we have is taken during intravitreal melphalan or topotecan injection. And we follow the safety guidelines that were put into place by Munier for that. We do have a protocol available at Children's Hospital now to take the aqueous humor at diagnosis and then to follow throughout therapy. That, of course, isn't considered excess specimen, but that's a research-related procedure. So for that, we do a very similar set of precautions. We make sure that there's no anterior involvement of the tumor or even ciliary body involvement. It's done under the microscope, and you have to make sure, of course, that the pressure in the eye is normal and that there's no neovascularization of the iris and that you have a good formed chamber. Aside from that, we use a 32 gauge needle and we keep the bevel up over the iris. So you can reach out to me and we can talk about the specifics of it more, but the main parameter is to make sure that it's safe for the child and that there's no issue to the anterior segment as it relates to tumor involvement.
Yeah, thank you so much.
Thank you. Glad to see you here.
Same here.
We'll do one more question if that's okay. This is one of the first questions you received for the panel. And it's from Joanna from Chicago. And she asked to any of the presenters on genetics, is there data regarding risk of secondary malignant neoplasms in the cohort of heritable RB1 patients with a 13q deletion syndrome? Does anybody want to take that one?
Am I overstepping? I'll take it if nobody else is rushing for that. So as far as I know, nothing conclusive. From our cohort at SickKids, in a study we never published, we looked at all 13q deletion syndrome patients. So just to remind everybody, 13q deletion syndrome is when a large portion of chromosome 13 is not present, so it's deleted. And that might or might not include the RB1 gene. And so we looked at all those patients and to see what types of phenotypes they expressed. So, and we also looked to see, does the deleted region also delete RB1? And what's interesting there is that in some patients that appear to have RB1 deleted, as the question shows, they didn't actually manifest with retinoblastoma, or sometimes they only had one eye affected. And we also had some patients where the RB1 locus appeared intact, and yet the patient still got retinoblastoma. So I understand the hypothesis that if this, I guess, low penetrance of retinoblastoma, so a less severe phenotype of retinoblastoma in these patients, would it also translate to maybe a less severe phenotype or different spectrum of second malignant neoplasms? It makes sense. I'm not aware of anything conclusive in the literature.
And that will conclude the Q&A session for this panel.